on. So I do have a few slides. I want to start, though. I know it's like everything's looking pretty ugly right now, so I want to start with some self-deprecating zit humor. I'm growing probably the biggest pimple I've ever had in my life, and I've named it Brett Kavanaugh. Okay, so just to draw some analogies here, some like skincare and politics analogies. What I want to do is to take my claws and to just start digging in there, right? I want to use violence on Brett Kavanaugh right now, meaning the pimple, of course. But it's not time. It's not ready to be popped yet. It's not time yet. We need to be strategic about our tactics. So instead of like clawing in, what I need to do is I need to apply the political power of salicylic acid, right? That'll bring us closer to the place where we can use our claws. So let's all be the salicylic acid on the patriarchy, the zit patriarchy. We can get through this ugly time if we do it together. All right, now I'll be a grown-up. Yeah, I'm an assistant professor at the University of Southern Indiana, and my dissertation work that I'm still working on, I'm turning into a book currently, is about criminal approaches to dealing with the problem of pregnancy and drug use. I call it the criminalization of pregnancy, and many other people call it the criminalization of pregnancy, but essentially this is the prosecution of a pregnant woman or person in general for a crime against the fertilized eggs, embryos, or fetuses that she gestates. This started, of course, in a big way in the late 80s with the so-called crack epidemic. The narrative there being that we have this generation of ruined children who will grow up to be extraordinarily costly. They will grow up to be inherently criminal and destructive, and so something needs to be done about it. Representative George Miller said of the children who were exposed to crack cocaine in utero, that these children who are the most expensive babies ever born in America are going to overwhelm every social service delivery system they come in contact with throughout the rest of their lives. So you might couch this in terms of we want to protect these vulnerable babies, but really the way that politicians are talking about it in practical sense is about the cost. What is the social and kind of just financial cost of these children? So the scope of the research that I've done and continue to do, I did an analysis on the state level of all introduced bills dealing with pregnancy-specific crime. I also did an analysis of nearly 800 arrest cases from South Carolina, Alabama, and Tennessee, where people were arrested and charged with crimes against their own pregnancies. And then I also interviewed prosecutors who were among the first in their states to use prosecution as a threat to encourage pregnant women to seek treatment, which we can talk about kind of the flawed logic there during the Q&A. There have been many punitive solutions to these various pregnancy drug crises, and they're very much related to the war on drugs in general. So we have these Just Say No campaigns. We've offered financial incentives for low-income women, especially low-income women of color, to be sterilized. We have also sought to take the fetus into protective custody, meaning that the person carrying the fetus has to go along with it, but this is happening outside of the scope of the criminal justice system, right? So you don't get some of those basic protections that you get in the criminal justice system. And then what I focus on primarily, charging the pregnant person with a crime. We focus here on irreversible damage, expensive babies, the idea that drugs are ruining some kind of maternal instinct, and then also, of course, the cycle of dysfunction, where we've essentially biologized poverty. We have these families, they just keep on reproducing, and they keep on being poor for some reason. It's almost like it's their fault or something. Maternal drug use in my research, I found compared to many things. Here are some of them. If you're pregnant and you use drugs, it's like taking a pistol and shooting the baby right through the mother's stomach, or taking a knife and sticking it in there. What a thing to think about. It's like drunk driving. It's like bombing a building. It's like injecting drugs into a child with a syringe. Or it's like driving without a seat belt. Which, of course, that means that the pregnant person there is the car, right? I'm going to skip it. I mean, the kinds of things that we see mostly is drugs. But I've also seen cases where someone attempted suicide and survived and was charged with a crime, where someone attempted or successfully terminated their pregnancy and was charged with a crime, where people were in accidents while they were pregnant and were charged with crimes, people who did not comply with medical orders and were charged with crimes, and I mean, whatever else. There have been cases where someone ate a poppy seed bagel and they were drug tested and arrested initially. There's a case where someone was running and a reckless endangerment charge was tacked on to this other criminal charge because they were pregnant and running. So the motivations here, when I talk to prosecutors about why they were doing this, they, in these 3 states, seem to be leading the charge. This one woman said that they had a day back in 1989 in family court. 3 babies, infants, had been taken into protective custody by police. So it just struck me as we had a baby, 2 babies born drug impaired with crack cocaine and 1 with heroin. And so in these 3 hearings in one day, it all just came to me that nothing was really, that this was a serious issue and nothing was really being done about it. And so this is an example of a prosecutor deciding that no one's doing something about it. What can I do as a prosecutor? Prosecute. Maybe we can prosecute our way out of this problem. In terms of tactics and motivation, one person said, when drugs are introduced in the womb, the child to be is endangered. No one is to say whether that environment is inside or outside the womb. And this is actually in relation to the chemical endangerment law that was introduced in Alabama. This law was explicitly introduced to deal with the idea of children being present in meth labs, but then this law was taken and applied to pregnant bodies. So in this analogy, the uterus is a meth lab, and that dangerous environment is a uterine environment that the government can then step in and regulate. We also see prosecutors talking about how they need to fix addiction and encourage women to do that. Unfortunately, encouraging them with a gentle work isn't enough. It's the velvet hammer of prosecution that sometimes inspires them to do the right thing and get into these programs. Every prosecutor I spoke with used this term, velvet hammer. You know, you're softening the blow by wrapping it in velvet, but you're still hammering a pregnant person, right? That's not very nice. Another quote from a prosecutor that essentially they need to be the parents to these irresponsible women. Say, you know, you have parameters, you have borders. You say to your baby or your child or your toddler, little Johnny, don't do that, little Johnny, and you're gonna get a spanking on your butt. And then they test you and they test you and you have to spank them. And you have to have some accountability there because you're trying to train them, right? In this bill, and it's hard, its intent is not punitive. And yet, you know, to get to that non-punitive intent, you're literally advocating spanking these women. And then another prosecutor said the ultimate goal was to use the heavy hammer of the law that would hopefully, you know, scare these mothers into trying to complete their treatment plan. Another said you're faced with a problem that needs a scalpel, maybe needs surgery, and all we've got's a machete to do it with, you know? So again, that's vivid and violent language. I asked the prosecutors if it was working, if these punitive approaches were effective in their area. They did not seem to know. And many of them seem to not think it was their business to know. Their job is to wield the hammer. That's it, that's all they can do. So one said, I don't think we have as many, we don't think we're seeing as many hospital cases from Tennessee and Mississippi, so fewer people coming from out of state into their state to give birth. We think they may not be necessarily coming to our hospital. They might be charged, right? So what he's saying here is that we don't really know if fewer women are using drugs, but we know that fewer pregnant women are coming to the hospital when they use drugs, right? Another said that they had no idea, said, I can't tell you it wasn't effective, which is, you know, I wouldn't want to build policy on that kind of a statement. Another said they had a relatively successful outcome. In this case, the successful outcome was a woman being held in jail throughout her pregnancy, giving birth to a healthy baby, using drugs immediately after she gave birth, and being locked up again. That is considered a success in their eyes. Let's skip on some things. When I did the analysis of these arrest cases, I did see some interesting patterns. So, for one, there was a focus on particular drugs that's incongruent with actual drug use patterns. So, you know, for example, I think methamphetamine is the area I've done the most work on, and I need to stop soon. But essentially, methamphetamine is being constructed as a drug that poor white people use. It is a white trash drug. And even though it is one of the least used drugs, you know, we have this built-up thing that it's this like huge problem ravaging America. But statistically, we have not seen that to be true. And yet, when you look at these arrests, there's a very heavy focus on amphetamine. I'm skipping some things here. So, what I'm working on right now is looking thematically at how we have constructed these racialized drug panics that are time bracketed. So, crack in the 80s and 90s, focusing on low-income black women. Meth in the 2000s, focusing on low-income white women and degenerate whiteness. And then opioids, starting in kind of in the 2010s, is when we start to see this focus. With middle-class white people, right now I'm looking at the effect of the 2016 election and the revitalization of concern about low-income white people who maybe voted for Donald Trump as it relates to the current focus on opioids. There is this tendency now to talk about the opioid epidemic as a public health crisis, which is appropriate and unique. Typically, we don't approach these things as health crises, we approach them as crime problems. However, in the context of pregnancy, our approach to the opioid epidemic has been just as punitive as the others. And I relate this back to eugenics. I argue that this is a new kind of eugenics, that we're eliminating the reproduction of non-white people, we're shoring up white supremacy by eliminating degenerate whites. And I'll close with this. Relating this to those quotes I shared earlier about why we're using the punitive route. A quote from Buck v. Bell, the Supreme Court case saying that it's okay to sterilize people against their will. This case has never been overturned. It's actually cited in Roe. Oliver Wendell Holmes wrote this decision. He says it is better for all the world if instead of waiting to execute degenerate offspring for crime or to let them starve for their imbecility, society can permit those who are manifestly unfit from continuing their kind. I'll save the rest for the Q&A. Thank you.
All right, hi, I'm Leslie Marie Buer. I'm not going to state my current affiliation because I don't really want to get back to them, but my former affiliation is with the University of Kentucky. And I actually got involved with reproductive justice while working in an underground strange exchange program in another state out west. And when I was working with that program, they constantly talked about how they saw their sort of illicit public health as sort of dating back to some of the illicit abortion services that were provided in that state. So I think there is a connection in reproductive justice between how we are giving people services that they actually want, that the state refuses to provide. And so this goes back to something they talked about in the first panel, where I think any sort of something that's trying to address the opioid crisis without doing some sort of Medicare for all or socialized medicine is a farce. The only way we really address the opioid crisis or anything like that is by having Medicare for all or some single payer system. And so as an example of that, I'm coming from a state in Kentucky where we had Medicaid expansion, which is definitely not single payer, but it is far better than not having Medicaid expansion, which is what I've experienced as I've moved back home to Tennessee. And so, for example, with opioid use, with Medicaid expansion, from the year before expansion to the year after expansion in Kentucky, we saw a 700% increase in people utilizing substance use treatment through Medicaid. So we desperately need expansion in this state, which is a possibility if we get people to vote. So moving on from that, as we talk about the opioid crisis, it is certainly a racist and classist response to it. And people have been very critical of the opioid replacement therapy, buprenorphine, for being racist in very particular ways. Methadone, the previous sort of opioid replacement therapy that was most used, is done in very highly stigmatized, highly surveilled ways that are generally available in predominantly poor or people of color neighborhoods. Whereas buprenorphine has been provided in nice clinics in the suburbs that are very much catered to whites. And there are many arguments that buprenorphine was only FDA approved because of the opioid crisis and because it was assumed that the opioid crisis was affecting white people. So it is definitely a particular response. There's also been a lot of critique saying, you know, as we have gone from this idea of a crack epidemic to the opioid epidemic, we have seen increased decriminalization in some ways of trying to, people advocating, well, we just need treatment, not jail. We need treatment, not jail. And I understand that critique, and I appreciate, I'm for decriminalization completely. But what's happening right now sort of looks like decriminalization from the outside, but I'm arguing it's actually not. So I've worked in counties in eastern Kentucky that are 98% non-Latinx white, and so it is very much a poor, some of the poorest counties in the country, and predominantly white. And so if you actually look at the criminalization going on in those counties, they have much higher incarceration rates than the rest of the state, except for inner city Lexington and inner city Louisville, which are vast majority people of color. So there is mass incarceration in Kentucky of people of color, but also poor whites in very different geographic areas. But I'm going to say that in Kentucky, when you go to Frankfort, the state capital, what they talk about is all those poor white people in Appalachia that we need to go save in eastern Kentucky. And women there who are assumed white, not all are white, but they're assumed to be white by state legislators. They do have access to programs that are not available in other parts of the state. However, these programs are not decriminalized. They are very criminalized. They're just criminalized through the Child Protective Services system. And so what happens is women are forced into these programs, and sometimes the women, I spoke to about 40 women who went through these programs, sometimes they self-identify as addicted. They say that I have a problem. I've been using heroin for 10 years, I've been using meth for 10, whatever. They self-identify that way. But a large chunk of the women do not self-identify as having a substance use problem, and they are shucked into these systems because they test positive once for cannabis. And so you've got people thrown into these systems who some have tested positive once for something, others who say they want treatment and they have problems, and they're mushed into these programs together, which is not good for anybody. And then they're losing their children to CPS, Child Protective Services, and furthermore, then they're getting criminal charges from CPS. And these criminal charges are neglect or something similar. Dependency is the other thing they're being charged with. And this completely prevents them from entering the labor market when they're done. It prevents them from getting housing, it prevents them from getting food. So they are not being put incarcerated, but they are definitely criminalized, right? And because after they get those charges, no housing from the state for the rest of their lives. Very hard to get re-enrolled into SNAP. And since the two primary employers in that area are healthcare and the school systems, they are banned for life from those employment possibilities. And so as we move through the opioid epidemic, or crisis, whatever you want to call it, I think it's important to realize that this might be a time to talk about decriminalization, but when we talk about decriminalization, it's really got to be decriminalization, not just getting people out of jail. We've got to get people out of all the state systems that are hurting them, while also providing state services that they actually want and they actually need. And I would love to see the dollars that are being spent on incarceration spent on, healthcare and housing and things like this. And you go to talk to county executives, and let me tell you, Eastern Kentucky, it's red, very red. And you go and talk, and they're like, we don't know what to do. The jails are killing us. We can't spend money on anything else. We're having to cut the schools. We're having to consolidate the schools. We cannot offer any sports teams at the schools because we're putting so much money into the jails. We need to stop doing that. And so I just want to talk, I'm also in Tennessee. I just want to point out a few things in Tennessee. So providers who work with pregnant women who use drugs in Tennessee and North Carolina tell me that the same practices, so also in Kentucky, what they're doing is if women are on doctor-prescribed buprenorphine, CPS is coming in and automatically removing their children, even if they are on doctor-prescribed bupe, especially if they're pregnant. children gone in most counties. In some counties, it's different because of local administrators. And women or providers in Tennessee and North Carolina are telling me that the same things are happening in particular counties because of particular judges or of CPS caseworkers. And, you know, I think you're going to talk about the fetal assault laws, and so I will not talk about that at all, but jeez. Okay, and, you know, and first, women are also being specifically targeted. Sorry, I wrote all this down and then I just gave it up, so now I'm trying to find my place again. Okay, so we also have long-acting reproductive contraceptives being targeted towards women who are incarcerated, and only towards women who are incarcerated, and any program that is only targeted towards incarcerated women is racist and classist, because the criminal processing system is racist and classist. So we can't have these programs coming from the Department of Health trying to target long-acting reproductive contraceptives, LARCs, at only one segment of the population. It doesn't work. And I think all matters of contraceptives should be available to everyone. They shouldn't be targeted at specific people. Also, what's going on in some southern jails is Depo is being targeted at people without any talk of the relationship between Depo and HIV risk, and without any informed consent. And if you go to any of the neonatal abstinence syndrome NAS presentations in East Tennessee right now, they are full of misinformation. It is just scare tactic after scare tactic after scare tactic, not based on anything that's related to evidence. And so that is extremely problematic. And, you know, instead of pushing all this stuff on NAS, what we could really do to affect NAS is get people housing, get people health care, get people jobs, and not by forcing people contraceptives. But anyway, I will move on.
Hi everyone, I'm going to use the mic only because it was handed to me, but I've very rarely been told I'm quiet. So if it's too loud, please let me know, because I do that. So my name is Erin Williams. I am a senior staff attorney with National Advocates for Pregnant Women. Hi, Lynn, wherever you are. Hi. And National Advocates for Pregnant Women is a nonprofit legal organization that works to secure the human and civil rights, health, and welfare of pregnant people. I will use pregnant women probably more often, but I also will interchange that with pregnant people to incorporate and understand that not everyone identifies as a woman, even when they can and have the capacity to be pregnant. I'd also like to think that we started off by explaining what reproductive justice is. I don't like to make the assumption that everyone knows that, because while I am a Black woman and every part of my body is RJ, and every part of my experience incorporates RJ work, I am still relatively new to the movement and understanding of it, and I like to make sure that people also know that that is possible, and that you should not make an assumption of an understanding of it, and that it is Black women-centered. So I appreciate that, and I also appreciate the recognition that the panel and also the room doesn't necessarily reflect that this is RJ conversation. So thank you. And I hope we make that a priority, or continue to make that a priority here in Tennessee. So what NAPW does, just to go back, is, again, assist and support pregnant people, pregnant women who are often targeted by state control and who are criminalized. And that, not surprisingly, looks like what we know, which is women of color, especially Black and brown women. That is, you know, low-income, poor white women. That includes also drug-using women. And I'm going to obviously talk about all of that, and specifically the drug-using women in Tennessee. So, what does that mean? I'm often in rooms, in fact, I was in a room yesterday full of medical students out in Harry up the street discussing like what that means. Because people often hear criminalization of pregnancy. What does that mean? And luckily, Grace came before me and really took away all of my examples, and you're coming after me talking about Tennessee assault law. So I'm going to keep this pretty brief, because truly, Grace kind of did it for me. But you know, it really is surprising and shocking. And so when Grace was going through her presentation, really you could have done even longer, because there's so many examples, truly. I was looking in the room and looking at people's faces, and we are surprised, and we should be surprised. No, maybe we should not be surprised, as Lynn frankly always reminds me, because inherent in this country, which means to me, inherent in each of us who stands here, it is we embody and we take in more racist, classist ideologies and practices than we frankly recognize, myself included. But so we really shouldn't be surprised, right, that we are constantly being, even pregnant people are trying to be controlled, because of course they want to control their bodies. And of course they want to control the bodies of people they feel, and when I say they, I am mostly specifically talking about the systems created by white men, but we play a part of that too. So anyway, what does that really look like? That means that when there are allegations of drug abuse, when there are attempts to access abortion, when there is even birth, like home births, right? And there potentially are pregnancy losses, that can result in not what a woman would have wanted in her home birth or in her laboring, that can frankly just result in her ending up either with a civil child welfare case or more often even a criminal case. And so we represent or help represent women across the country, including in this very state, including right now, we are supporting a woman in your state of Tennessee who is charged with murder related to her pregnancy, which is insanity. And what that means is, she is or was a pregnant woman who was also using drugs, meth specifically. She went into labor. She was carrying this child to term, was hoping for this child to live, and the child did not. The baby died a few moments after the delivery. And when that occurred, instead of treating it like a health issue, right, and a loss, they decided to charge her with murder under the theory that her pregnancy loss her drug use while pregnant caused the death of her baby. And more specifically, that after she delivered, and while the umbilical cord was still connected to her, she was still transferring the drugs in her body to that now born child. Right. And I know Lynn already mentioned this, but I think it's worth reiterating often that these laws that they are using, like feticide or murder or not fetal assault, which you'll get to, was specifically made for pregnant women, but those laws were specifically not made for it to apply to pregnant women. A feticide law, for example, was created so that if a woman was pregnant and she was hurt by her partner in some way, and that resulted in the death of the fetus, that was supposed to apply to third parties, to third people. But more commonly, it is now being applied to women in their actions, or sometimes even inaction. Also same for murder statutes. So over and over again, you were seeing these connections, like what was talked about in the first panel, which is why I'm glad we started off with talking about what Roe does and what it will look like with this upcoming Supreme Court, because a lot of the language to support getting rid of abortions is being used to prosecute women and to punish them in a whole bunch of different ways, essentially saying what we know people believe is that the thing inside of you, whether it is a fetus, an embryo, or fertilized egg, is just more important to you, and that we women are held to a higher standard, and we should be able to protect and control and guarantee every single thing. And frankly, as a Black woman who, prior to coming to NAPW, was doing work in trial courts, was representing people, because I was a public defender in New Jersey, I felt as if abortion was certainly my issue, because I'm a woman, and that is important to me, but it was not at the top of my list. It just wasn't. And it wasn't until I started dealing with these issues that I understood that if I don't understand the ways that abortion can be applied, it is going to impact the people in the communities I care about the most. And I just want to make sure that is always connected, because I think it is easy, maybe not in this room, but maybe I am speaking to someone to understand that when we are ignoring the ways in which abortion measures and personhood measures are used or can be used in other and more complicated ways, and we're not having full conversations about that, then we are ignoring the impacts on everyone. So I just saw a sign for time, so I'm going to pass this on. Thank you.
Hello, I'm Mary-Linden Salter, and I'm the Executive Director of TADIS, which is a very long acronym, but basically it's the Association of Addiction and Recovery Support Providers in the state of Tennessee. I am going to talk about the fetal assault law and then talk about some of the things that we're doing after. Good news, the law was sunsetted and is no longer in effect. Yes. The law was passed in 2014, and it was kind of a knee-jerk reaction to a lot of people's fears about what was happening with the opioid epidemic and the number of NAS cases that we're presenting. I would point out, however, that the issue, which really got everyone to act, was when TennCare, our Medicaid system in Tennessee, came to the state legislature and gave testimony about how much it was costing. That really was, I think, the impetus for the fetal assault law more than anything else. But at the same time, what TADIS did with a large cohort of collegial partners in this is we started an effort to repeal it pretty much the day it was passed. And so that cohort did a lot of different things. We did a lot of educational activities. We did a lot of things to actually educate people on what NAS was. We did a lot of things to educate people about MAT. The fact is, if you're on MAT, medication-assisted treatment, you have the exact same likelihood of having a child with NAS as if you were using any other kind of opioid that might not be prescribed. So getting treatment doesn't mean your risk of NAS goes down, and I think that was a hard thing for a lot of people to understand. So we had a lot of educational efforts. We really used that year to bring together, like I said, a large cohort. It certainly included Healthy and Free Tennessee. Interestingly enough, it also included Right to Life Tennessee, who was also on board about this issue. They thought it would lead to abortions, actually. So they were our partner on this. And as well as county commissioners and all kinds of others. That said, it went to, the bill was set to sunset automatically, and we had to make a case about why it should be sunsetted as opposed to reenacted. And we effectively made that, believe it or not, in subcommittee. It's kind of hard for a bill not to get out of subcommittee, and I think the fact that this bill didn't even make it out of its first subcommittee was a testament to what we did on the ground in order to make sure that people really understood the myths and the fallacies around this legislation. That said, there were a number of things that we recommended in that paper that have, in our white paper that we did about the fetal assault law, and this was a huge white paper that we disseminated across the state, like 14 pages of Tennessee research about the impact of this legislation. And there were several recommendations that didn't get enacted, which led to our follow-up work, really. So, two things that I want to focus on in those recommendations. One is around the fact that we don't have a licensure category for treatment facilities for women that allow them to have their children with them. We have some kind of pseudo look-alike treatment facilities that kind of try to do that by hybridizing different kinds of things. But until women can actually keep their children with them in treatment, then their access to treatment becomes a real problem, and their real goal and mission is to keep their families intact for the most part. So without that kind of access, we don't get the long-term access to treatment and keep families intact, which should be the goal. The other thing that we really worked on was around access to continued Medicaid coverage. Tennessee right now has a limit of 7 weeks postpartum, and then you lose your Medicaid coverage. And without a Medicaid gap plan, that really becomes problematic. Very few people can have treatment postpartum, 7 weeks, and be effectively, in recovery. And they certainly don't get access to contraceptive coverage or long-term medical care or anything like that without some kind of a Medicaid gap plan or Medicaid coverage that would continue beyond that. So that's been a real gap as well. Tennessee is actually lucky in its Medicaid plan that residential treatment has been a covered benefit. And this is kind of get into weeds a little bit, so pardon my vernacular, but Tennessee had something called a cost-effective alternative in place in our Medicaid plan that allowed residential treatment to be used instead of inpatient care for people needing addiction treatment. That has been banned now by CMS. So Tennessee had to go back and file a new waiver this year in order to get residential treatment to continue to be covered for our Medicaid population. That waiver is still in process. It has not yet been approved. And that waiver, even when approved, will limit coverage to 30 days, no more. So we have a real continued problem in that. And the cost-effective alternative was something that was covered under federal parity law, meaning you couldn't regulate that type of care any more than you would medical coverage. It had to be provided on par. With this waiver, that parity protection goes away. So we will lose federal protection under the law with that waiver as well. One thing we did really gain with this is a lot of our education was effective. When I wrote the white paper, there were 11 Tennessee facilities across the state that would accept pregnant women in treatment. There are now 15 solid ones, and I say solid because there are many others that will do it on a case-by-case basis. So we really did grow out the network of treatment providers that would take pregnant women and a certain amount of acceptance of serving that population. I do want to say, somebody talked about the crack baby epidemic, and I hate to even use those words, but that's how it's described. A lot of the initial research on that population has been found to be mythology. And what I want to point out is there is research right now going on with some of the babies who were diagnosed with NAS at birth. That research recently was released, literally last month. And so far, the only effect that has been found is something called, and I can never pronounce this one right, encephalopathies, whatever, the smaller head circumference. And whatever that word is, somebody say it for me. So that was also true when the initial crack babies were being researched as well. And even though that was a finding, there was no long-term or residual effects found. So yes, your brain size and circumference may go down, but no long-term effects have been found to date. And I think that's actually a promising thing to point out. One of the things that we've also had to fight since then, there's a federal regulation in 42 CFR that governs the release of information around addiction treatment. Addiction treatment is is a much more heavily regulated practice of release of information than any other kind of medical treatment. And that was done in the 70s in order to give people adequate privacy so that they would seek treatment. So we've had that in place for a long time. There was an actual effort federally in the last 2 years to take away those protections. We actually successfully fought it, and as of about a month ago, even though the House voted to take away those protections, the Senate did not. And in a reconciliation bill process, those guidelines that would have erased those protections were removed from the bill. So we're very hopeful that that will remain in effect. As we pointed out, this is one of the only disease states that's actually criminalized. And one of the things that what we try to point out is that access to treatment shouldn't be criminalized. And so we're hopeful that that will help foster a new movement of realization about that. One of the things we also had in our paper was a discussion of recovery courts, which are basically courts where if you have a certain type of addiction or drug-related charge, If you choose to go to treatment, there is a process under which that charge could be nullified and your fines taken away and all that, so that you don't have the charge on your record. And if you complete treatment during your jurisdiction under the court, then you actually get access to treatment, strangely enough, much more robustly than if you didn't go through court, which is a part of the problem with the whole recovery court process. Anybody should have access. You shouldn't have to be criminally charged in order to get better access than anybody else. But what did come out of that is something in Tennessee that has come to be called baby courts. So this is a replication of the recovery court concept, but it's done in a family court setting, so that if there are DCS charges, that basically those baby courts can treat the mom in a similar way, so that her charges or any intervention by DCS kind of will go away as long as she stays in compliance with this treatment plan that is mandated by the court in order for her to keep her children. So that's something that you're going to hear more and more about. There are 5 courts currently in Tennessee. Davidson County, which is Nashville, it was the original pilot site, and that's continuing to be followed, and DCS is trying to replicate those courts around the state of Tennessee. So I think that's something to keep our ears out about. I just said that the disease, this is a disease that should not be criminalized, but one of the things that the panelists have already pointed out is the fact that the opioid epidemic was seen very differently by the population and by legislators. And I think one of the missions of TADIS right now is to change the vernacular about that. We try very hard not to call it an opioid epidemic, we call it an addiction epidemic. And hopefully everybody can start to change that verbiage, then we can get people to understand about that particular issue. One of the top statistics that gets talked about is that 77,000, I think it is, people died last year from opioid overdoses, and that's more than all the people who died in the Vietnam War. It's a striking statistic. But the same year, 88,000 people died of alcohol-related illnesses. So we have an epidemic that people are not talking about, and I would hope that we could change that verbiage as well. Thanks.
Unfortunately, that's all the time we have today. I know that was super quick and a lot of information right at you. I'm sure our panelists would love to talk to you after if you have individual questions for them or want to get their contact information. There is a lot to be learned, and I want to thank you all so much for being here and taking the time to talk about this. I know this is a heavy way to start the day, and we have even more heavy, fun breakout sessions coming up. So yeah, I'm going to give you all that moment. We have about 4 minutes before the breakout sessions start. Get ready to go.